before we move fully over the fence into unresectable metastatic disease, which is where there's a lot of discussion to have, Jonathan, there's been a lot of chatter in the academic community in the melanoma field regarding the neoadjuvant concept. But this is, for docs in the community, this is not breast cancer, right? So true neoadjuvant with a primary tumor in place is not the idea. Mm-hmm. It's more, patients with bulky nodal disease typically and so on. I would maybe, for at least today's discussion, not use the term neoadjuvant, but maybe pre-surgical therapy. I know your group's been very active on that topic, both in research and to some degree in clinical practice. So I'd love to hear your thoughts on, BRAF inhibitor-based therapy in that population, immune checkpoint, TVEC. This kind of, you have a patient in front of you who you think surgery is possible and wouldn't be overly morbid, but you feel as though you might be able to, minimize morbidity of surgery or, with an upfront surgical approach. So walk us through how you think about that.
So if you're borderline resectable or maybe unresectable, but we think we can get you to that point, usually, obviously, we first assess for a BRAF mutation, and I think that's our agent of choice at that time because it has its quickest onset of action, BRAF plus or minus MEK, to get you to the resectable stage. If the patient is not BRAF mutated, then we usually go on to an immunotherapy. For the same principles, try to get them to a resectable stage. All the tumor doesn't have to go away, it just has to make surgery easier for the surgeon and for the patient. Again, thinking about the functional and cosmetic defects that we're going to make. And then as far as TVEC is concerned, there's a current clinical trial using neoadjuvant TVEC followed by surgery versus surgery alone, and we're currently participating at that within that trial at Moffitt as well. TVEC, I've been using for a lot of patients with stage 3B, 3C, particularly the patients who don't want to go on systemic therapy. They're BRAF wild type that may not want the possible toxicity of immunotherapy. It's very well tolerated. It's very easily given, and the patients, about a third of the patients are doing quite well on it and with a good response. And it really doesn't burn any bridges. So if it doesn't work, then we can go ahead and start giving the heavier hitters the systemic immunotherapies. And I think that's part of the theme here that you're talking about. Why use adjuvant therapy in some cases when we have good therapies if the patient does recur with systemic disease? So I think a lot of the thought process, if it doesn't burn any bridges, we still have plenty of powerful therapies in the future, but it's helping some patients.
Yeah, and what kind of time window are you talking about? So in terms of duration of exposure, exposed to TVEC or for BRAF inhibitor-based therapy, what number of weeks or months are you aiming for?
So for the systemic BRAF and immunotherapy in a pre-surgical setting, we look at 4 to 6 months of therapy and then bring them to surgery. For TVEC, the average length of TVEC time to response is about 4 months. So if they're not responding by 4, 5, 6 months, then that's probably not the appropriate therapy for them. And it's not uncommon to see these patients, just like some of the immunotherapies, have disease that gets the disease burden grows while on therapy for the first couple of rounds of TVEC, and I think, Georgina, you know that as well from some of your trials that you presented yesterday in the poster, that some of this disease can grow and then will eventually respond.
And that's probably a really important clinical point if you're taking care of a patient, especially because this is going to be, I find in my practice, the patients who actually have the most difficult psychological, emotional component to is if they can see the cancer. Yeah. If they have cancer all through their body but they can't see it, it's less stressful than if it's a mass here. So if you're treating a patient and you're treating it but it's still getting bigger, you need to really counsel them that we understand and that this is part of the process, and because that's where you can really start to lose people.
And I tell them that up front.
Yeah.
I said this might get worse before it starts to get better, especially if we're doing an immunotherapy neoadjuvant approach or TVEC.